Hello again, this is Dr. Hunter with Mentor Moments, Growing Beyond Failure. I am an OBGYN, your OBGYN, here to talk about a lot of different topics. Today, we're going to talk about a big one. Episode 7 is going to be about home births, safety, risk, and real talk from an OBGYN. Please like, subscribe, follow me on all the platforms you can find me on, and we're just going to kind of get into it. So I know this is a big topic. I know this is a little bit of a controversial topic in a way. First and foremost, this is not a podcast, an episode, a YouTube video disparaging home births. I am not going to say that today. That's not where I'm going. What I want to know is, and what I not want to know, but what I want to portray is that everyone is not a candidate for that. Everyone who does it does not also have great outcomes. And so that's where we're going to go today. So one of the big things that kind of prompted me to talk about this, and I'm going to tell you a story, is that back when I was in training, I was on, I think this was sort of a night shift. I was on call on labor and delivery, and I get a phone call. I was one of the it's called upper level residents and lower level residents. So our residency program is 4 years, and upper level is a third or fourth year resident, while lower level resident is a first or second year resident. So the upper level residents have a little bit less supervision. All of us are all supervised, but have a little bit more autonomy to do certain things and make certain decisions. So there's a lady that came in, and I'll never forget this because this was a black couple who just wanted to really just were afraid of the hospital, because this is back when there were a lot of things about maternal mortality and how black women are twice as likely to die from birth than white women. And it scared a lot of people. And so this woman decided to choose a home birth. And overall, all in all, don't get me wrong, she was a good candidate. And what happened is that while she was laboring, there was no monitoring, right? There's no fetal monitoring at home. So while she was there, she basically went for a walk, and they listened to the baby on a Doppler. Like we have this Doppler we use in the office all the time. You put it on the baby, listen to heartbeat for however long you want to. And then let's say the heart rate was about 140 for the baby. You leave, she goes for, I think it was a 30-minute walk, comes back. The midwife that was there, and I don't believe she was a certified nurse midwife. She was I think she was a lay midwife, but she was there and couldn't find a heartbeat, and tried for a while, at least 10 minutes, couldn't find a heartbeat. Calls EMS. EMS finally gets there maybe 10, 15 minutes later, puts her in an ambulance, gets her to the hospital. I scan her personally myself with the ultrasound that we had on labor and delivery, and I put the Doppler flow on, no heartbeat. The baby had passed. And that was probably one of the hardest things I had to deal with as a resident at that moment, because it was such a preventable thing. And in a situation where I just felt like I could have done more if I had her close by, like she was there at the hospital. And so that's just one example. Now, don't get me wrong. There are hundreds, maybe even thousands of women who have babies at home in America and have successful deliveries. And so the problem is, when you have successful deliveries, everyone is not a good candidate, but though you do it, I think some people then feel like, oh, everyone should be able to do it because if I did it, you can do it too. But that's not always the case. So one of the key factors in all of this is a midwife. All midwives are not created equal, but I do think that midwives are the key for our field, a key to kind of help get the mortality rate down, decrease the morbidity for not only moms and babies, because midwives have a specific perspective that physicians like myself don't have, right? I'm a trained doctor. I was a trained chemist, right? I was a chemistry major in college. I then went to medical school and was trained to learn just about literally all of medicine, but I didn't do a lot of bedside learning. It was more of books. And then third and fourth year of training was about, going out in the hospital and learning the ins and outs of medicine, but more pathology, medications, how it all fits together. And then I did 4 years of residency where then I was at the bedside, making decisions, delivering babies, doing surgeries, just there on the fly, making fly rash decisions, having to run a code as a second year resident when no one else was available, just based on the situation. Like, there's a lot of different things that are thrown at you, but I was never trained on what nurses call bedside nursing, right? Being there at the bedside, understanding very little nuances that moms and babies have, and how to usher them into the labor portion and then delivery, and taking a different perspective more so than the cerebral portion that I was trained to do. Some OBGYNs are better at this than others, but I think that midwives have a key point in this is because they know how to activate certain parts of labor that I just would never be able to do. And if I did, I'd have to go to midwifery school really to get there, or nursing school then, because our frame of thinking is totally different from a midwife's thinking. Not for better, not for worse, but just different. And I think that midwives are going to be the key to really helping at least obstetrics kind of increase the success rates, decrease all of the morbidity, decrease a lot of the mortality that comes with birth. The problem, every midwife is not created equal. So big key things to know, and I just wanted to jot down some numbers because I hate when people just like want to take my word for it and be like, who is this guy? Like, what do the numbers say? I'm a big numbers person. And so when you look at just total numbers of home deliveries and you look at percentage of deaths, right? The worst outcome possible. You do all these things to get to your baby, and then, oh my gosh, the baby is not alive anymore. So looking at just numbers of mortality rates for neonatal mortality rates for planned home births versus planned C-sections. For planned home births, that mortality rate was 0.2%, right? 0.2%. It's a very low number, but still 0.2%. Hospital mortality rate was 0.09%. So literally the mortality rate for home births was 2 times higher. If you extrapolate, take out of that moms who have babies with congenital anomalies or known anomalies, the risk was actually worse. So home birth neonatal death rate was 0.15%, right? So first it was 0.2, now 0.15. A little bit lower. But for planned hospital birth, that neonatal mortality rate was 0.04%. So it went from 0.09 to 0.04. So 3 times more likely to have your baby pass away at home than if you had a planned hospital birth. What I think is a piece of this, right? I just talked about midwives. So the Journal of Midwifery and Women's Health did a study, and they looked at perinatal death when comparing home birth versus a certified midwife. So, and they did not describe certified nurse midwife versus just a certified midwife. I'll talk about the difference in a second, but just certified, they have to have a certain degree, certain training, have so many deliveries, etc. So when you look at the neonatal death rate, it was actually flipped. So home birth that was attended by a certified midwife, the death rate per 1,000 was 0.35 per 1,000 births for a planned home birth with a midwife that was there with you. A hospital birth attended by a physician, the neonatal death rate was 0.64, almost twice as much. And so I know what some of you are going to say. Aha! That means I shouldn't go to my doctor. I shouldn't deliver my baby at the hospital with the doctor, because if I do, I'm more likely to have my baby have issues. And that's not the case. The thing that is not reported in this study as much, and it's not powered to find a difference for, was for the type of birth, right? High risk versus low risk. And that is a big key component. A part of my job is to constantly figure out what's the worst thing that can happen and how do I fix it, or how do I see around the corner before that thing starts to show its ugly face. And that's sort of my training. So I'm trained to look at birth and look at deliveries a little bit different than someone who's trained and they just do normal, uncomplicated, just sneeze, push out a baby, bam, wow, pow, boom, there's a baby. Like, totally different. And I think that when you look at a certified midwife and what deliveries they will be comfortable in, and you look at a physician, an OBGYN, or even a family physician that's trained in OB and what they're going to be comfortable in, the difference is going to be stark. So OBGYNs are trained to really deliver some of the most high-risk pregnancies, high-risk babies. And you don't want a midwife really in there, because then they can't do the thing that may need to happen, right? Sometimes babies are telling us they need to be born right now, and via either an operative delivery, which we talked about in the last episode, or C-section. But a midwife can't do that. They can assist in C-sections. Some can, but not all. But they can't do the C-sections per se. So that's why I think the mortality rate is higher for physicians than it is for a certified midwife at home doing her home birth, is because home births, you want to be very selective. You want to be selective for so many key components, right? Sometimes maybe you don't even want to do it for first-time mom because labor takes so long. Maybe it's a mom who's had 2 and 3 babies before, and you know that naturally, usually labor is faster if mom has had vaginal deliveries before. The moms who are not good candidates for home births, in my opinion, and from the studies, from what I've seen, are moms who've had 1 or more prior C-sections, moms whose BMI are in the question of like what the top BMI is, but going into the pregnancy with a BMI over 40, moms who have very complicated medical history, either chronic hypertension, chronic high blood pressure on medications, lupus, infectious diseases like HIV, or recurrent things like syphilis, or different things such as that. Moms who have autoimmune diseases, again like lupus, or who have other autoimmune diseases. Not so much hypothyroidism per se, but maybe very uncontrolled hypothyroidism. There's a lot of different key components to it. And I think the other moms who are not very good candidates are moms who have oddly shaped uteruses, where there's a heart shape to it, or a what you call bicornuate uterus, or a uterine didelphys. There's certain types of shapes that a uterus can be, or moms who have had protracted labor, meaning their labor course is just totally thrown for a loop. Maybe they're laboring at home and all of a sudden they spike a fever, right? That's a mom whose labor is going to slow down because now they have an infection. The problem is, the big issue really with any high-risk mom trying to deliver a baby at home, or any mom in general, is when you try to have a baby at your house, there is not a team waiting in the wind ready to go right then and there within a few seconds. In the last video, I told you, when a baby shows that it's ready to be born, or it's telling us that he or she is in distress, you have seconds to minutes to act, not hours. And I believe that in the core of my heart. Sometimes you can do things to buy yourself more time, but you don't necessarily have that. Sometimes what happens is you have moms who just need more fluids, and when you are in labor, it is, and especially active labor, and I've seen this. No, I have not delivered a baby, but in active labor myself. But I've seen this. Sometimes it becomes very difficult when you are having these back-to-back contractions that are so painful. It's hard to hydrate. It is very hard to stay hydrated. Sometimes you don't want to eat. Sometimes you really can't think straight. Sometimes you just want to just focus in on and get into the zone of just, breathing through, humming through contractions. You're not really worried about anything else. Well, the problem is dehydration is a problem when it comes to your baby. When it comes to your baby getting blood flow, when it comes to your uterus getting blood flow, it needs fluids. If you haven't hydrated enough before, then when you get dehydrated, then there becomes all these issues. When you don't have the strength to push and get to that point where you can push at home, there becomes issues. If you're at home and you're pushing for 4 hours and that baby's just not coming out, there are issues. So that's why you need specific people there who know what they're doing and they know when to call for help. And the key is they got to know when to call for help way before you really need it. Because when you truly need that help and they're not there, seconds to minutes. Remember that, seconds to minutes, because your baby needs intervention sometimes right now, not 2 hours from now. So the other piece about, the midwives and why I think they're such a key is that training is really important. So when you look at the different types of midwives, especially in America, now I'm not talking about other countries because other countries have a different setup. There are some women who are called midwives who don't necessarily have formal training, but they have what's called an apprenticeship to training. And those are really more like what you call lay midwives, who they don't really go to school. They just learn from another lay midwife on how to do stuff. And then here they are saying, I know how to do it, right? It's like a mechanic or like a kid learning from their father on how to become a mechanic, and then later on in life they become a mechanic. Different scenario, because cars, though they may need help, they don't really have to have help right now. You can just leave them there and then boom, help do what you need to do later. Different than life, right? Life and death situations usually need intervention right now. So there's a lay midwife. where there's no formal training, there's no oversight. They cannot prescribe medications. There's a certified professional midwife, CPM, where there is some training, but it's more like apprenticeship, and there's sort of apprenticeship programs. They're under the rule book of the North American Registry of Midwives, the only group that is, as far as midwives are concerned. They don't work in hospitals. They're more likely to do home births, and they cannot prescribe any medications. And so if you ever seen somebody or know somebody who's had a baby and they need help, they're in a bunch of pain, that midwife necessarily can't help them in that sense other than helping them get more, figure out what over-the-counter medications they can take or more natural remedies that they can take to kind of help with that situation. And then there's certified midwife and certified nurse midwife. So a certified nurse midwife has to have either an RN, registered nurse degree, which you can get as an associate's, or a bachelor's of nursing degree, which is a BSN, Bachelor of Science Nursing, which is a BSN, versus a certified midwife, which does not have to have a nursing background at all, which is kind of surprising to me because I don't know if I would trust that person as much. Now, there may be some who are out there who have had years and years of experience, and they are a nurse midwife. They weren't a nurse before, but they were doing something else in healthcare, and then they decided to become a midwife. Different story, but just there's a big difference in who's taking care of you. And I think it's really important to, when you are trying to decide if you should have a home birth or not, and you're trying to figure out who's going to help me, to really look at the training and the background of the person that you are looking into, because that's important, in my opinion. You don't want Joe Schmo, Linda Joe, just from the street calling himself a midwife, and they don't have any training to do such a thing. This is your child, right? This is your baby. This is a little unborn child that you don't even know what they look like, whose nose they have, whose mouth is theirs, whose ears do they have. You have no clue, but you're trusting an individual, and you want to make sure that that person truly knows and has an understanding on how to take care of not only you, but your baby. And that is why I think the training is super important, because you want somebody who is trained and has had experience in not only the good, but also the bad, because sometimes bad things happen to the most normal of moms, and it is just uncontrolled. Sometimes it's out of nowhere, but you want to know that people, especially at your house, right? You're inviting them in your space, know what they're doing. The intermediary of all of this is a birthing center. Birthing centers, I think, are fantastic because they provide sort of that home-ish environment. There's not a lot of intervention as far as like inductions, augmentations, anesthesia, epidural, spinals, all those things. There's not a lot of intervention per se, but you have an IV depending on where you go. Some places say you don't need it. Some places say you do. But you have people there to help you with certain interventions, and they can do certain things up to a certain point, and then they can send you out if they think you need a higher level of care. And so to me, home births provide a more stable, predictable situation, more so. I said home birth, birthing centers provide a more stable scenario than a home birth does. And so that's sort of my piece there. But again, don't get me wrong. I'm not saying home births are not warranted. If you look at moms in other countries, sometimes you have no choice. Sometimes the nearest hospital is miles and miles away. And if you don't have somebody in the town where you are who can help you have your baby because you can't necessarily drive or get to a hospital, then you need somebody who knows what they're doing. And so I think that, like I said, there is a special place for that, but you just have to be mindful that it's just not the case for everybody. The one thing that I didn't touch on, I was waiting on somebody to text me back about this. One of my midwife friends, a good friend of mine, is the number of deliveries you need to become a midwife. And so I want to put something in your brain and your mind, is that, again, when we talk about training, okay, so a certified nurse midwife, which I think is the cream of the the crop as far as like what training you need, right, to become a certified nurse midwife. Is basically a master's program. So you get a bachelor's degree and then a master's in midwifery. And you have all this training. You have to do over 1,000 hours, like practical hours where you're like in a clinic on labor and delivery with patients, talking to people, over 1,000 hours. And then the one piece of information is very hard to find is how many deliveries you have to have, how many vaginal deliveries you have to be a part of. And for each of the different types of midwives is different. But for a certified nurse midwife, certain programs have different numbers. But on average, roughly, it's about 50 deliveries. Now, keep that in mind. That's 50 vaginal deliveries before you then graduate and then you, boom, do your thing. Compare that to someone like myself. I had to have, at a minimum, 250 vaginal deliveries, 150 C-sections before I graduated residency. That is over 400 deliveries before I stepped foot out and could call myself someone's personal doctor. So, I mean, we're talking about a 4 times more deliveries, which is why a newer doctor out of residency sometimes feels like they have more experience than a newer midwife. I think midwives, it takes sometimes years, months to even years to really feel like you could be on your own. And some people are more confident than others, but it just takes a while because like that's a big gap, right? We're talking 400 deliveries, and that's just a minimum 400 deliveries versus 50. And that's for a certified nurse midwife. Those numbers go down as you get further and need less and less training. And so again, I say that home births are cool. They are nice. They have a niche. And I think they are important to help keep the number of maternal mortality down. But on the flip side, that neonatal mortality now doubles. And so I think if everyone then shot and was looking at home births, neonatal death rates would climb rapidly in America. Can't speak for other countries, but here. And so I think it's going to be super important for you to understand self-reflection. Am I a good candidate for a home birth? And if you feel like you are, then kind of seek that out. If you want to compare, right, you want to go to a traditional OBGYN office and then talk to a midwife about a home birth. If you're going to choose a midwife, I would suggest choosing a certified professional midwife because the training is more regimented and you sort of know what you're going to get for the most part, if that makes sense. You know someone is a little bit more comfortable. They have training. There's certain specifications and things that they need to get that title of certified professional midwife. So, and you can compare, and I think that's totally fine to do. But do understand that everyone is not a candidate. Just because you successfully had a baby at your house with all those fluids and all that stuff in your house with that pool, that nasty pool, don't bring that in that hospital. It's different, totally different. So that's my 2 cents, my take. Thanks again for tuning in. I'm Dr. Ahan Hunter, OBGYN. Please like, subscribe, follow for all the things. Find me on TikTok, find me on Instagram, find me on YouTube. Have an amazing day and tune in for episode 8 as we continue on this deep dive in all of OBGYN. Have a good day.